Good morning, everybody, and welcome to the first Total Virtual AIOS conference. Now, I'll be speaking something about the elevation maps or the Scheimpflug imaging. Why elevation-based tomograph? Because if you give a glass or a spectacle to an optometrist and an ophthalmologist will just give you the power of the glass, where an optometrist will give you the anterior posterior curvature, lens thickness, overall diameter, centration. So he'll give you the actual lens performance. So that is the importance of elevation-based tomography. The basic assumption in a surface tomograph is that we take a simulated K. All ophthalmologists are usually accustomed to a simulated K. However, the elevation-based tomograph, it is a high-speed rotating camera in which it actually takes the elevation points on the cornea, anterior surface of the cornea, the posterior surface of the cornea, the iris, and actually it then correlates it with the best fit sphere. It is like, for example, if you take these points from the center of the earth, these height have no meaning whatsoever. However, if you take a baseline of the sea level, we can have an actual elevation and depressions we can see. So similarly, in the cornea, this dark line is the cornea. Whatever it comes, whatever the part comes up below the best fit sphere is the depression. The other one is the elevation, or the flattening or the steepening. This is the elevation curve of the anterior surface has a curvature of about 8 mm. So we take a float of 8 mm and everything appears all right. Here it is an astigmatic cornea in which we can see that the elevations, this horizontal line is above the best fit sphere. So this axis is the flatter axis, and this is the steeper axis, which has gone, the periphery has gone behind the best fit sphere. This is again a similar thing. This is a regular astigmatism. And so instead of a best fit sphere, here we have taken a sphere of 8.13, which is the average of the K1 and K2. However, if we take a toric ellipsoid, if we choose this as a toric ellipsoid, everything becomes normal. So regular astigmatism, we need to take a toric ellipsoid so that we can know these elevations. But here we have differential elevations in the inferior part on the posterior surface. In this elevation is actually an ectasia. It is not an astigmatism. So in this case, we have to take a best fit sphere. If we take a best fit toric ellipsoid, it will not have any meaning. So a BFS should be taken for ectasia and best fit toric ellipsoid to find out about the regular astigmatism. Another thing is the decentered apex syndrome. If this reference axis passes to the center of the cornea, it's all right. But if this reference axis is slightly does not pass to the center, we can have an asymmetric bow tie or a skewed radial axis on a topograph. However, if we see the elevations, this reference axis is here, the center of the cornea is here. This gives a false impression of an inferior steepening. So the elevations actually are the true way of knowing the curvature of the cornea. This now coming to the maps, the axial map is the similar map to what we get in a topograph, in which we use this equation of the refractive index of the first minus the second surface divided by the radius of curvature. So we can have this map, which is similar to a topographic map. Then we have a tangential map in which 1.5 mm of zone is points are taken, and instead of using the mu1 minus mu2, the Snell's law is used, and this gives a localized power in that area. So in the tangential map, we actually see an increase in the power in the periphery. This is the what we call the positive spherical aberration. So tangential maps usually are only used for localized defects in the cornea. For example, if we have flattening of the cornea due to corneal opacity, or we have a marginal degenerations, only then this tangential maps are of any meaning. Then we can have a true net power map in which we calculate the anterior power and the posterior power in that particular point, and then we get the true power at that point. This is not simulated K. This cannot be put in the IOL calculation formula, because all of those take the simulated K. This is important only for post-refractive surgery, when you want to get the true net power of the center of in the visual axis, and secondly for the KPD, which is the keratometric power deviation. If there is a significant difference between the true net K and the simulated K, then that means that the posterior surface is not in a line with the anterior surface. Then we have the pachymetric map. We can have so many the pachymetric values from all over the cornea. The important is the thinnest local, the pachy apex, and the pupil center. We can actually know how much this thinnest local is below or above the apex of the cornea for inferior steepening and keratoconus. Then we have the pachymetric graph, in which this thickness from the central to the 2 millimeter, 4 millimeter, 6 and 8 millimeter zone, we can have two standard deviation above or below. So we can know that this thickness, whether it is a normal change in the thickness or it is a ectatic, in which there is a differential thinning in the center and suddenly it comes back to normal. Then we have the enhanced ectasia. Enhanced ectasia means it is the correlation of ectasia with the pachymetry. Normally, if there is ectasia, the generalized best fit sphere becomes steeper, because these steeper values come into play. So what we do is we take the values of the part of the thinnest area, and we remove that, and then we calculate a flatter best fit sphere, and this gives a enhanced ectasia. Here we can see the best fit sphere of 6.57. We take a best fit sphere of 6.67, and this gets enhanced. So we get the cone, we can see clearly. There's another thing in which we can compare the maps. We can have a map of 2017, 2019, 2019, 2020. We can see over the 3 years, there hasn't been any change. We can even take the difference in the two maps. Then we have to see if there's any error in the reading. We can see the skewed radial axis here. We can see that here it looks like as if there's inferior steepening, but on the Bellin-Ambrosia, it's normal with a thinning, which is good. And then there are so many other things, but
Sir, I request you to please conclude.
Yeah, it is the last slide. Then we can have the higher order aberrations going from the first order to the 8th order aberration. We can know the exact, and also the cataract pre-op, in which we can get the posterior corneal curvatures. We can get the root mean square of the central 4 mm zone, higher order aberration. We can get the positive asphericity of the cornea.